I'm going to go.
I think that's one well.
Yeah.
Really?
So I was I came in on Fort Rugby.
Okay. So I understand that.
Oh, you have, what I saw. All right, Brian.
Right, but eventually,
well,
since I will be doing work on the inpatient setting that's more distributed,
Sandy's
and
coming
we
back,
dispense
right?
opiates on the inpatient setting, not outside, just information.
All right, I'll go ahead and introduce Dr. Jennifer Simon. She is ambulatory care faculty in the Department of Pharmacy Practice. And she is going to be talking about building clinical pharmacy services in a primary care setting. And I will brag on Jennifer because she never says it herself, but I always say this. She was the first pharmacist in West Virginia to go through the collaborative practice process and have a collaborative practice agreement in place at her site. And still the only one?
Yeah, but I think there's a few that are
In the process.
Yeah.
So that's something that we're very proud of Jennifer for, and something that she can be a great resource for other people if they're trying to pursue that in West Virginia. So I will turn it over to Jennifer.
All right. So it is something that I'm going to talk about today, is sort of the process that I went through to get that collaborative agreement. And we'll talk about collaborative agreements in general, but we're not just going to focus on collaborative agreements. I also really want to focus on how we can just get pharmacists into outpatient clinics. That is the biggest step that we need to take. Whether we have a collaborative practice agreement and we change medications is one thing, but just getting the pharmacist into the clinic is probably the most important thing we can do. So I'll tell you a little bit about myself. I graduated in 2009 from pharmacy school and worked for Kroger as a retail pharmacist for 3 years. And during that time was when I really I compared what I was seeing in practice to what I saw in school. And in school, I worked in a couple of clinics that were affiliated with a hospital, and they did have pharmacists in them. And then, of course, in the inpatient setting, we have pharmacists working directly with physicians and rounding with them. So it's a very good team. But I didn't see any pharmacists in physician-owned outpatient clinics. And that's where, when I started working for Kroger, I saw a very big need for pharmacists in that setting. So I decided to go back and do a residency with the intent of working in a clinic in eventually today. So my residency was in North Carolina at the University or at Campbell University for the first year. I worked in a family clinic, or family health clinic there. And then I also worked, for my PGY2, I worked at UNC, and they had several clinics. They actually had lots of specialty clinics, a cardiology clinic, geriatrics clinic. They also had a family health clinic as well as an internal medicine clinic. So I worked in all of those. And that's where I learned more about pharmacists billing for their services, but then also just seeing pharmacists being used to their full capacity in that setting. So that's what we're going to talk about today. Before we get started though, I want you to think about what you would do if you were put into a clinic. So imagine that you are recently hired by a family medicine clinic in Charleston. You're the only pharmacist that's ever been in that clinic. And you do Precept students for the University of Charleston. You have 2 APP students each block and 2 IPI students each semester. The population of the clinic is listed here. So you have adult and pediatric patients. Mostly adults though, and most of them are low income and are on Medicaid or Medicare. The clinic recently joined an ACO. How many of you know what an ACO is or have heard of it? It's becoming more popular. So an accountable care organization, or ACO, is basically a group of providers, healthcare providers. So it could be clinics, a group of clinics and a hospital and pharmacies all working together and being reimbursed by Medicare as a group to provide better care for their patients. So basically they get money from CMS to provide better care. If they can show that they provide better care by the end of the year, they get more money for that. So that is an ACO. Your clinic recently joined an ACO, but you found that you have poor performance in your clinic with your diabetes patients specifically, so you have a high number or high percentage of patients with an A1C greater than 9%. You also have your cardiovascular disease patients don't have the correct cholesterol lowering medication, basically. So these are 2 areas where the clinic needs to be better. So during the presentation, kind of think of what you would do if you were put in that situation. What services would you offer the clinic? How would you integrate yourself in the clinic, being the first pharmacist there? What barriers might you encounter and how would you overcome those barriers? And then how would you incorporate your students in the clinic to both help the clinic but also allow the students to get the most they can out of the experience? So again, we'll talk about collaborative practice agreements. We'll also look at barriers to implementing a practice in an outpatient clinic. We'll look at different types of services that you could provide in an outpatient clinic. And we'll also look at opportunities for IPPY and APPY students in those clinics. So I've listed here the definition of collaborative practice as defined by the West Virginia legislature. This is actually defined differently in any state that you go to. So in our state, we say it's the practice of pharmacy where one or more pharmacists jointly agree to work in conjunction with one or more physicians. And this is where the pharmacist can perform specific functions that are specified in the agreement. So they have conditions and limitations in the agreement that tell you how the pharmacist can practice. So the basic purpose of a collaborative practice agreement is to expand the scope of practice of the pharmacist. So we have things that we can do under the Pharmacy Practice Act that we can do already in a clinic. But the CPA is supposed to expand that practice, expand the services that we can provide. So for example, if you have an agreement with physicians to change patients' medication therapy under that agreement, then you can do that if you have a CPA. But let's start with why do we even need collaborative practice? Is there a real need for pharmacists in the community setting? So I want you to think about where you work. And you might work in retail, you might work with infusion, you might work in inpatient. What sorts of situations have you encountered where if a pharmacist had been working in the patient's primary care office, what would have been different? So think of a situation, maybe an error was made, maybe a patient is not receiving the best care they could have received. Think about a situation and kind of write it down or talk to the person next to you actually, and we'll kind of go over some of those situations and compare them. Nobody wants to talk to each other. So yeah, pair up with each other. Think about a time when you saw an error and you thought, you know what, I think the pharmacist could have prevented this. You work in retail.
All the time.
Yeah.
Yeah, they weren't really studying that aspect.
Well, different pharmacies, there's no report pharmacy, especially for 9 years.
Oh, okay.
VA, insurance.
Okay.
It's been a long time since I've actually been in this family.
In the pharmacy. Okay, so let's think of some of these examples. So I saw a lot of you talking in the back, and I know you work in outpatient clinics, so you probably have some good examples. But anybody, Jane, I think you raised your hand earlier.
Well, I know when I was practicing in infusion pharmacy, to me, if I would have had the ability to, you get the labs, the vancomycin lab, it's Friday at 6 o'clock and the labs come through and there's the dosage needs adjusted. It would have been nice if I had the authority to go ahead and make the adjustments, to have the, call the pharmacist, the physician after hours and go through all that process. Or sometimes they wait till Monday till it got adjusted. That would have made it so much easier on our end.
Yeah, absolutely. And then what are some examples that you guys have found?
I have a lot of patients that I start either diabetic therapy or blood pressure management inpatient, and I know that that's going to get changed as soon as they go home and back to a diet that is not so tightly controlled as in a hospital. So I know it's going to continue needing adjustment over the next few months, and I wish I could always call someone and be like, hey, keep tweaking this for the next 3 months at least, please.
So they might follow up with their physician for the hospital follow-up visit, and then usually they don't address the other concerns that they had, except unless that's the reason that we're in the hospital. But and then they might follow up with their physician 6 months later, and then what's happening in between there. Yeah. So it would be good if a pharmacist could kind of make sure that they get to their goal in that meantime. Yeah. Any examples? from you guys?
We're just kind of talking about Michelle's potential practice site and if she would get one. And so.
Oh, okay.
We get some some physicians would write the order, dosing and labs per pharmacy, like for high code. A lot of antibiotics, of course, wouldn't do that, but you always wonder, you write that order thinking, you probably cover it, but there were some physicians that expected you to do that, and they would decide later if you called, they really didn't want that. They just wanted to order.
Oh, really? So wait, they would write the order for the pharmacist to dose and monitor, but then they actually didn't want that?
No, I mean, they would sign the order at a later date, but you were like, like Friday evening when you got your labs, you changed the dose, and the doctor wanted you to do that and would sign it, but you were kind of on your own, you really didn't have a signed order yet. You didn't have the original order that said pharmacy to dose.
To back you up, yeah.
Right.
Okay.
So you wrote the labs and you wrote the orders. And several physicians do that now.
Yeah, okay.
But you wonder where it is as far as
Yeah.
the law.
And actually, pharmacists can have collaborative agreements with physicians in the inpatient setting, so situations like that could be improved, or if they use it correctly.
Right.
Yeah. All right, any other examples? So yes, there are definitely reasons why we need collaborative practice in the inpatient setting, retail setting, and in the ambulatory care setting. One of the biggest reasons is prescribing errors, and I think Dave talked about this quite a bit actually in his presentation. In the inpatient setting, there are many studies looking at the 4 areas of medication use. So prescribing, and then dispensing, administration, and monitoring of medications. Those are the 4 areas where medication errors could occur. And the 2 areas where the most errors occur are prescribing and administration. And who prescribes typically? Physicians or MPs or PAs. Pharmacists sometimes in a collaborative agreement will prescribe. And then who administers typically? Nurses, or if it is in the outpatient setting, it's usually the patient. So pharmacists have done very well with keeping the dispensing errors at a minimum. But these 2 areas, prescribing and administration, especially prescribing, are areas where maybe we can have an impact on helping to improve or decrease those errors. And so here's an example. In the outpatient setting, there was one study that found 18.6% of all prescriptions that were written in one family medicine practice contained a prescribing error. And the pharmacist actually in this study implemented a few interventions to improve prescribing and did show a significant decrease in those errors. The other reason that we need collaborative practice is chronic disease. Chronic disease is very prevalent in the U.S. in our patients. So if we look at statistics from 2012, half of all U.S. adults had at least one chronic condition, 1 out of 2. And 1 out of 4 had 2 or more chronic conditions. And chronic conditions are something that are managed best in the outpatient setting. So we had like the example of the diabetes patient, where you could start the perfect therapy in the hospital and are controlled at that time, but then once they leave, it's up to the outpatient setting, the physician in the outpatient setting to control that. So chronic disease really needs to be managed more appropriately in the outpatient setting. And here's a chart showing the number of chronic conditions in the U.S. population, and this again is in 2010. You can see that, I don't know if my cursor shows up here, yeah. You can see that if you add all of these together, this is a majority of Americans have more than, or 1 or more chronic conditions. So 52% total. The most prevalent conditions are listed here. So the highest percentage of chronic condition is, or the patients with the highest occurring chronic condition is hypertension, and hyperlipidemia, and allergy, sinusitis, and it goes down the list. So you can see CAD at the end, thyroid disorders, COPD. So looking at these conditions, what do all of them have in common?
They're most relevant chronic conditions in adults 18 and older.
Yeah, so they're very prevalent. How do we manage them? medications. So that's what they all have in common. Some of them, there are non-pharmacologic things you can do to help manage those conditions, but for the most part, patients with these conditions need medication, need to be managed with medication. And they need to be monitored, they need to be dosed appropriately. And we are the experts with medication, so we really need to be involved in their care. If we look at healthcare spending, we can see that over a third of all total healthcare spending is spent on patients with 5 or more chronic conditions. And so you can imagine with these patients having 5 chronic conditions or even more than that, they have many medications, they could interact with each other, they need to be dosed appropriately, they could have renal failure or hepatic dysfunction, and that also affects their medications. So this is an area certainly where pharmacists need to be involved. Then if we also look at percent of all inpatient stays by chronic conditions, again, 39%, almost 40% of inpatient stays are for patients with 5 or more chronic conditions. So you can see where errors can occur in patients with that many conditions. So I'll talk for a minute about what types of collaborative practice have been successful. And again, all of these situations, all these studies I talk about do involve pharmacists in the care. So if we look at therapeutic outcomes specifically, so one study, it's actually highlighted down here at the bottom, Medical Care is where it was published. That study looked at, actually found that pharmacy services significantly improved therapeutic outcomes, including A1C, LDL lowering, blood pressure lowering. They also found a significant benefit in INR monitoring, weight and BMI, inappropriate medication dosing and monitoring, as well as prevention of adverse drug events. So this has been found in all settings, in the inpatient setting, the outpatient setting, and the retail and community setting too. So again, these are collaborative practice agreements between pharmacists and physicians in all these settings that are showing improved outcomes. We also have improved economic outcomes. The first one listed here by Chisholm, Burns and Associates found that 20 of 126 studies reported positive economic benefits. They specifically looked at all studies that had ever been published in the literature up until 2009. And they found, they looked at cost minimization studies, cost effectiveness, cost utility, and cost benefit studies. And they found that the services that helped patients the most were DUR interventions, medication education for patients, MTM, disease education for patients, adherence education, and chronic disease management. So all of these services provided by the pharmacist showed a benefit, an economic benefit. The last study there was also a systematic review by Perez and Associates, and it also looked at inpatient ambulatory care and community pharmacy services. And they looked specifically at 3 areas, so pharmaceutical monitoring, pharmacotherapeutic monitoring. And this was basically encompassed adverse drug reaction monitoring, drug interaction assessment, formulary compliance, and also the process of rounding with physicians for the inpatient studies. And it also looked at targeted drug programs, so this would be programs that were specific for one drug class or one drug specifically. So for example, INR monitoring would fall into that category. And they also looked at disease management, so chronic disease management. And this study found that for every $1 invested in clinical pharmacy services, $4.81 in reduced costs was the outcome. So in only half the studies in this systematic review, however, were rated as good or fair quality. So the authors of this study did say that there is a need for more studies looking at economic outcomes in pharmacists who are involved in CPAs, but they did find a benefit overall. Now, if we look at, so again, this last slide was both inpatient and outpatient and retail pharmacy, but if we look at this outpatient setting specifically, there have been many studies in family medicine clinics that include pediatrics, internal medicine clinics, as well as specialty clinics, so cardiology clinics, nephrology clinics. Any specialty that you can think of, there is a pharmacist somewhere in the country that's working there and helping those patients. Studies have found improvement in chronic disease management, as I've already mentioned. Medication therapy management has also improved outcomes. Transitions of care has also been very helpful. So has anyone heard of a pharmacist working in a transitions of care sort of program in an outpatient setting? Yeah. What is it exactly?
So I think the thought behind it is that when a patient goes into the hospital, there's a lot of medication changes that don't necessarily get communicated back to the outpatient setting. So it's really kind of connecting those two settings and making sure that there's no medication errors related to things getting changed around while the person is in the hospital, but you're also trying to prevent them from going back into the hospital again by any preventable medication changes or monitoring, things like that.
Exactly. So it actually, outpatient clinics, a lot of pharmacists don't realize this, but outpatient clinics actually get paid more if they complete a patient visit within 7 to 14 days of the patient being discharged from the hospital. So basically, if the patient follows up with them within that 7 to 14 days and then is not readmitted within 30 days, they get paid a higher amount for that visit than if they had just seen the patient for a follow-up visit. So there's a big push in the outpatient setting to get all of these patients in to see their physician within that 7 to 14 day time frame. And there have been studies looking at, well, can we involve a pharmacist in the team looking at the patients during those visits? And they found that having a pharmacist as part of the team does significantly decrease their risk of being readmitted to the hospital. Medicare wellness visits have also shown improvement in outcomes. Anticoagulation monitoring obviously has shown an improved time and therapeutic range for patients taking warfarin. And then the last thing I have listed here is decision support. What do I mean by decision support? It's kind of a new buzzword that's starting to, or phrase, I guess, that's becoming popular. Has anyone heard of decision support for physicians?
Often with IT.
Sort of, yeah. So it actually does have a lot to do with IT. So a lot of it is electronic. So it's kind of ways to help the physician make a decision, a therapeutic decision in the moment. So if we can provide them with all the necessary information that the patient that they need in the moment to make the decision. So for example, if it's a dosing decision, if we happen to pop up their creatinine clearance right that second when they're making that dosing decision, it helps them tremendously. Well, there's also studies looking at pharmacists providing that decision support and whether or not that changes outcomes for patients, and it actually does. It does help tremendously. So these are all examples of successful things that have worked in many settings that pharmacists could do if they were to go into a physician's office. So now we'll get into sort of the law part of collaborative practice agreements. So this varies by state. 48 states do allow for collaborative practice between pharmacists and physicians. And some of them go as far as actually licensing the pharmacist to become a practitioner, and they actually recognize the pharmacist as a provider in that state. And these 3 states are New Mexico, North Carolina, and California. So when I worked in North Carolina, I worked alongside a pharmacist who had a clinical pharmacist practitioner designation. She had a license by the state to practice as a CPP. And she did have a collaborative practice with the physicians, but the benefit of being a CPP and being recognized by the state as a provider allowed her to bill for her services and actually be reimbursed as a provider at a much higher level. Now, again, that would only work if she billed private insurances that were recognized by the state. If she billed CMS, she could only bill at a very low level, a nurse's level, basically. But it was very nice to have that designation. Some practices only allow for a pharmacist to work with one physician, some allow for them to work with multiple physicians. And then some of them are very patient-specific, so you can only have an agreement with each individual patient, whereas others in North Carolina, for example, you had an agreement with the clinic as a whole, all of the physicians, and that encompassed all of their patients. So you didn't have to have a different agreement for each patient. You had one for the entire clinic. And some of these vary on what they allow the pharmacist to do. Some of them don't allow for laboratory monitoring, some do, some allow for referrals to other providers. So it just depends on how you write the agreement. Here in West Virginia, we have 3 boards that came together to create the collaborative practice law. The Board of Pharmacy, Board of Osteopathic Medicine, and the Board of Medicine. And they, again, I already showed you how they define collaborative practice, but it is a specific agreement between a patient, the physician, and the pharmacist. So for every individual patient, we have to sign an agreement, which can be limiting. So it's much nicer to sort of have one agreement that covers the full clinic, but here in our state, we need to have one for each patient that we see. And then the protocol, again, is just a detailed written agreement between you and the physicians, but they do in the law limit you to these 4 things. So implementing, modifying, and managing drug therapy according to the agreement. So you do have some leeway there. Collecting and reviewing patient histories, obtaining and checking vital signs, and then here it talks about labs. So it says we can order screening labs that are dose-related and specific to a patient's medications, which sounds very limiting, or, and they use the word or, not and, so or are protocol-driven and outlined in the collaborative agreement. So the last section there kind of sounds like you could order any labs that you needed. It could be preventive labs, it could be point-of-care testing labs. So actually, in the point-of-care testing that we did just a couple days ago, there's a lot of discussion about this, about whether retail pharmacies could actually provide point-of-care testing for patients and provide a peer treatment based on those, or I guess treatment based on those test results. And again, this would be under a collaborative agreement with the physician. So from the wording of our law here in West Virginia, it looks like that would be a possibility. So there are 3 requirements for pharmacists to have a CPA. The first is that you must be obviously licensed here in West Virginia. You also have to have $1 million of professional liability insurance. And then you also have to have one of the following backgrounds. So basically, the higher amount of training that you have, the less clinic experience you need, and vice versa. So if you have a residency training or you have a BPS certification, that would be sufficient, or a certified geriatric practitioner designation, that would be sufficient to have a CPA. Or if you have a PharmD with 3 years of clinical experience and an ACP approved certification program, you could also have a CPA. But the certification needs to be in the area of services that you're providing. So for example, if you're going to see patients that have diabetes and manage their diabetes, you would want to have the APHA diabetes certificate, for example. And then lastly, if you have a BS Pharm and 5 years of clinical experience, as well as 2 certifications, then you could also have a CPA. There's a 3-step process for obtaining a CPA. First, the pharmacist must submit an application to the Board of Pharmacy alone. So you fill out an application, and it's only your information on the application. I'll show it to you in a few minutes. And then you submit that to the Board of Pharmacy, along with the fee, along with the $50 fee. Then that application is reviewed during a full meeting of the board. So you really need to take into account when the board is meeting. So if you're trying to plan ahead and plan your collaborative agreement, they only meet 5 to 6 times a year, and it could even be in Morgantown that they're meeting that month when you need to be there. So kind of keep that in mind. Then once your application is approved, you and your physicians can submit a collaborative practice protocol to the medical boards, the Board of Medicine and the Board of Osteopathic Medicine. And this just depends on if your physicians are MDs or DOs, which one you would submit it to. If you have both, you would submit to both. And then that actually has a $100 fee for each board. And they do not review the protocol during a full meeting. So you don't have to plan around when they're having a meeting. You simply submit it, they look at it. If they think it agrees with the law, they approve it. And they give you an email or an official letter stating that they approved the agreement. And then after that, you can start. You can start working in the clinic and collaborating with the physicians. So here's the application that you would submit to the Board of Pharmacy. So again, this is only submitted to the Board of Pharmacy, and this application can be found on their website. So the first page here, we just have background information. So we have your address, name. Then this is where you put your academic degree, any certifications or residency training you have. And then on the last page, this is all the clinical experience that you have in a work environment. Oh, sorry. And it's probably very hard to read this, but this is available on their website. So again, it's just 2 pages, very easy to fill out and turn in and submit to the board. Then you could probably leave it off. The next couple ones are probably hard to read. The next couple slides are the CPA protocol. So again, this is the protocol that once your application is approved, you would submit this to the boards of medicine or osteopathic medicine. And this is pretty much you can create your own template as long as it agrees with the law. So the template I used was actually, was I guess worked or approved by all 3 boards, but it's not actually available online from anywhere I could find. I obtained it from Dr. Lucas here at the School of Pharmacy. But you can modify it in any way that you need to as long as it agrees with the law. So here we have a list of our providers, and then my name, and then this first part here just sort of gives an overview of my authority in the clinic, so nothing very specific. But then below that, it outlines my scope of practice. So here you can see that it actually says that I'm allowed to improve medication management and continuity of care by initiating, modifying, continuing, and monitoring drug therapy, ordering, performing, and interpreting lab tests relating to medication monitoring, assessing patient response to therapy, counseling and educating patients, and administering certain medications, including vaccines. And then here is where I've listed all of the possible things that the physicians could refer a patient to me to do. So anticoagulation therapy, diabetes therapy, lipid therapy, smoking cessation, hypertension therapy, asthma therapy, osteoporosis therapy, renal dosing of antibiotics and other specified agents, and then adult immunizations. These are the only things that we listed on my agreement, but there is nothing in the law to say that you couldn't change that and add something if you needed to for your specific practice. Then on the second page, at the very top, it specifies that patient must provide, or we must have patient's informed consent for every referral. And I'll show you what that looks like in a few minutes. And then we have documentation and reporting just below that. So this just says that for every encounter with the patient, the pharmacist needs to actually document what they did and then provide that documentation to the physician. And typically we use a SOAP note for that documentation. The protocol is actually good for 2 years, is what this red box, the third red box says. So the agreement actually does need to be reapproved every 2 years, and you need to resubmit fees to the boards every 2 years. Under record keeping, it states that each individual agreement with a patient must be kept on record at the clinic, whatever the physician's primary practice site is. And then at the very bottom, it says that the physician could override this agreement and back out of it at any time. Then on the third page, you just get everyone's signature, including yours. So again, this is what you would turn into the boards of medicine, the boards of osteopathic medicine. This does not need to go to the board of pharmacy. So just to clarify that. The next couple slides are the patient-specific protocol, and this also needs to be submitted to the boards of medicine and boards of osteopathic medicine. This is part of the protocol that the patient will see. And you'll see that it's a little bit redundant, so a lot of it is exactly the same as the overall protocol that you submitted. So it basically goes back to your scope of practice, informed consent, documentation, and alteration of protocol. And then at the top here, though, you have the physician's written name. Right next to that, you have the patient's written name. Then down here at the bottom, you have the physician's signature, as well as the pharmacist's signature right below it. And again, this has to be filled out for every patient that is referred to you. The last page is the specific order for that patient. So again, this also needs to be filled out for every patient. You have the patient's name, date of birth, diagnosis, and then what specific service they want you to provide. The physician can then put comments here if they want to limit anything you can do, for example, or if they want to expand upon it. And then they sign again here, and the patient's name then goes here, and the patient signs here. So this really is the only sheet that the patient will see. So they do see what the order is that their physician has signed, and then they can also read this statement here. And this statement says that I, the patient, acknowledge that I have been referred for management of the therapy listed in the order above, in accordance with the law. I understand that at any time I may withdraw from participation in this agreement, and that I have been informed of the cooperative procedures that will be used pursuant to this protocol. So, that is all of the forms that you need to fill out. What does everyone think of the patient-specific protocol? Are there any potential barriers that you think you could run into with that form? And again, this is these 2 pages and then the last page here. I've sort of highlighted it with boxes, what the potential problem could be.
It sounds like they're just writing a prescription for you to do these services, is essentially what that looks
Yeah.
like.
Yeah, so it's basically an order or referral, basically, yeah. Does anyone think that it could be time consuming?
Yes.
Yes, very time consuming. So every patient that you see, and we could see, there are honestly some days where I've seen 10 patients in a day, in a morning. Every patient you need to fill this out for. Now, again, you only fill it out for each patient once every 2 years, so that's the good thing. It's not every encounter, it is just every patient. But this can get very time consuming, especially when you're starting your service. And part of it, I guess, is probably the biggest barrier, I think, is the physician's part of this. So the physician has to sign in 2 places. They have to, if the physician filled out this entire form, you probably wouldn't get very many referrals, in my opinion. So what I've been doing is going through and filling out as much of this as I can prior to the physician seeing it, so they only have to sign the 2 places and they're done. So that's how I've been doing it. And luckily, we really haven't had any pushback from patients. So the other thing that I kind of worried about when I started the collaborative agreement was that patients were going to read this and they were going to say, oh, well, this says that, I can terminate this agreement at any time, is there maybe something I should know about? Are you not qualified to do this? Why do I need to sign this waiver, sort of? What is this exactly? Am I signing away my rights if you make a mistake? So luckily I haven't had any patients, refuse to sign or give me any pushback. So that's very good. So it's actually worked out pretty well. Any questions about that whole process of submitting to the boards or starting up the CPA? Yeah.
What kind of primer are your physicians giving the patients? Are they saying like, I'm going to have you see our pharmacist for this, she's really great, like what are they saying to the patients when they're making the referral?
That's a really good question. So it depends on the type of referral. So if it is an anticoagulation visit, it's kind of automatic, where it's just expected that they're going to see me for those visits. But if it is a referral for something else, like for diabetes, for example, it helps a lot if the physician really sets it up and says, hey, by the way, I'm referring you to the pharmacist. I am still going to see you, by the way. The physician is still going to see the patient. And, just so you know, I'm making this change today, but I want you to follow up with the pharmacist over the next couple of months so that we can refine the treatment, change it a little bit if we need to, and then when you see me the next time, hopefully your disease state will be controlled. So it's really nice if they give them that little primer. Sometimes they don't do that, and then when they go to schedule with me, they're really confused about why they need to come in to see me. So it does work much more smoothly when they do that. I think, yeah, you can turn back on, sorry. Okay. So I have a couple of slides on billing in the outpatient setting. And again, you don't have to bill for your services to have a CPA agreement. You can have it and not bill. But I get so many questions about billing that I thought it would be good to include this as well. And again, this only pertains to billing in the outpatient setting in a physician-owned clinic. So there's actually 2 types of clinic in the outpatient setting. One is hospital-based, that's actually affiliated with the hospital. And in that setting, the billing is a lot different. You bill on a level of service, and you can have a facility fee in that bill. And you actually get paid quite a bit. So the pharmacists in that setting actually do get reimbursed very well. But in a physician-owned clinic, that is where the problem with reimbursement comes into play. So in a physician-based clinic, we can bill incident to a physician. Does anybody know what that means? What does incident to billing mean? Cassie, you're shaking your head, yes.
So you're technically not the provider in that situation, and if I'm not mistaken, the provider has to be like within the vicinity. So if there's an issue or something like that, you can contact them, or they can be there to provide assistance, but they don't have to come in the room or anything like that.
Exactly, yes. So we can see the patient and actually provide the service, but we are not actually the provider in that situation. We are billing incident to the real provider, which is their physician. And the physician, you're right, has to be somewhere on the premises. And they also, so in order to bill that way, you also have to meet all of these criteria. One of them, I believe it's, yeah, so here it does say a physician or Medicare Part D approved practitioner, which could be an NP or PA, needs to be on the premises, but not necessarily in the room when you're providing the service. The other kind of caveat to this is when you bill incident to, you do not receive the payment for the service. The physician actually receives the payment. So then if you have a contract with the clinic, they pay you, that's how you get reimbursed. You don't actually get reimbursed directly by CMS. So the other requirements are that the patient must first be seen by the physician. So the patient actually has to establish care at the clinic before they see you. They cannot just come into the clinic, first time they've ever been there and see you, because you are not their primary care provider. So the physician has to see them first and then refer them to you. And then the other requirements, the physician must continue to see the patient. So usually the way this works is the physician will see the patient at least once for every 2 to 3 visits that the pharmacist sees the patient, is typically what most clinics will do. The service must be typically furnished in a physician's office, and it must be medically appropriate to be provided in a physician's office. It must also be, so this states that the services provided by a pharmacist must be within the pharmacist's scope of practice. So that, as stated by the state's Pharmacy Practice Act. So this is where we are limited to, if we don't have collaborative agreements that we can do, we can only do what is in our scope of practice. So this is where collaborative agreements really open up what we can do in these clinics. And the other ones are services and supplies must be furnished in accordance with state law. And then the last one here, this states that the pharmacist must be an employee, but actually this has changed recently. So in 2014, I believe it was, they changed this so that your relationship with the clinic does need to show an expense to the practice, but it could be something as little as using their exam rooms, for example, or using their supplies. So you don't actually have to be an employee of the clinic to bill incident to in the clinic. A couple other things that I wanted to point out. If you do bill incident to, you do not want to bill on the same day that the patient sees the physician. If we do that, if CMS gets 2 bills on the same day, they only pay the lesser of the 2 bills, and that would be the pharmacist's visit. So you only want to see the patients if you can on days when they don't see the physician. Now, the way we do this in my clinic is if a physician does say, hey, can you come in here and talk to this patient, counsel them on this and this, of course we still do that. We just can't bill for it, is the only problem. So if you are going to bill for a service, it needs to be on a separate day from when they see the provider. Again, we also need to document our services, and it has to show that we evaluated and managed their disease state. So they have to have a diagnosis from the physician. We then take that diagnosis and put it in our assessment and assess the problem, and then we write a plan for that problem. And then we do not have to bill incident to. So there are other ways to bill for our services. One is for MTM. We can bill MTM in the outpatient setting. And we can also bill for Medicare annual wellness visits. Through CMS, we are recognized as providers for Medicare wellness visits, and that is something that we can be reimbursed for. There was a study done in North Carolina where they actually looked at the feasibility of only providing Medicare annual wellness visits and if that could pay for a pharmacist's salary. They found out that it could. If the pharmacist was able to see, I believe it's 1,070 patients per year, then that would pay their annual salary. And they thought, from their calculations, that was only half of the pharmacist's time. So we could clearly, if that was the only service we provided, we could pay for our salary in that way. Okay. Any questions so far before I move on to the next part? So the next part I'm going to talk about is barriers that I've encountered and barriers that other pharmacists have encountered in other clinics. And they're all exactly the same. So I decided to group them all together. But I'm actually, on every slide, I will cite a study that was done. It's the SCRIPT study. And in that study, they looked at putting 2 pharmacists in 4 clinics. And this was done in Pittsburgh. and in collaboration with the University of Pittsburgh Medical Center. It was funded by them. They put 2 pharmacists in 4 different clinics. I think they split them basically two clinics for each pharmacist. And these were retail pharmacists. They had never worked in a clinic before, and the clinics had never had a pharmacist in the clinic before. And they basically looked at this process of integrating the pharmacist into the clinic over a 3-month period, and they interviewed the clinic staff, the pharmacists, and the providers to find out if there were any trends in this process and what problems the pharmacists in the clinic encountered along the way. So one of the barriers they found was lack of understanding of pharmacist skills and training. So this is very, very common. And this is, so I put on the last slide that these could be actual barriers or potential barriers. This is an actual barrier. A lot of times when we come into the clinic, especially if the physicians have never worked with the pharmacist before, they really don't know what we can do. They really do, like we mentioned earlier, they do think that we only dispense, we only count meds and dispense it and counsel patients, and that's it. They really don't know what we can do. So the way to kind of overcome this is to have a physician champion if you can. So if there is a physician who has worked with a pharmacist before and they know what you can do, or if they've never worked with a pharmacist but they just believe in what you can do, that really helps. In my clinic, it was the physician who owned the clinic, Dr. Bowden. He, at every turn, wanted to expand my services, get me to do whatever I could do. He referred the most patients to me in the beginning, and he really sort of set the example for the other physicians in practice. Another thing you can do is complete a needs assessment. So look at the clinic, look at their patient population, figure out what they need the most. So if they really need anticoagulation monitoring, focus on that and say, this is the service I can provide for you, and start there. But you also want to maintain the flexibility. So you do want to start small, start with one service, but then be open to doing other things. So in my clinic, I did start with anticoagulation services because that was what they needed the most. And then that sort of got my foot in the door and led to more and more interactions with the physician. So every time I made a dose suggestion, a dose change, or happened to find something, a drug interaction in the patient's medication list when they were coming in for an INR, and then pointing that out to the physician, those little interactions along the way opened them up to other referrals. So then I started getting referrals for disease management or for drug information questions. And then eventually the clinic decided that they had a problem with transitions of care, and they really wanted me to help with those patients as well. So that's when I started seeing a lot of transitions of care patients, and actually now that is the primary thing that I do. That's the biggest part of my services. The other very, very important thing that I absolutely recommend is attending every meeting you can. every meeting you can go to in the clinic gets you, so in those meetings you get physicians in a room with the clinic staff, and they're very frank and outspoken about what they need the most, what's bothering them, how services can be improved, and what they think needs to be done. And if you're there, you can volunteer to help. You can actually see what needs to be done and get a better understanding of how to incorporate your services into the clinic. Another barrier that I found was interruptions in workflow. So this is really just a perceived barrier. Physicians look at the idea of bringing a pharmacist into the clinic and they really think, oh no, they're just going to interrupt my schedule, this is not going to work out. But actually, it works out pretty well. So the best thing you can do to prevent this is just prepare ahead of time. Know what patients you're going to see and when the physician is going to see them, so that if you are coming in and out of the room when they're seeing the patient, it runs a lot more smoothly. And you can also utilize students here. Initially, the thought was that having students in the clinic was really going to interrupt services, but it's actually enhanced them. So I'll use our transitions of care patients as an example here. The way we do this is I will, for every patient who has a transitions visit with a provider, I will go in and see them first and conduct the medication reconciliation, a very thorough one. I look at their labs, I look at their other disease states, figure out what changes we need to make, and then I huddle with the physician before they go in to see the patient and make those recommendations. And then they go in, implement the changes, and the visit's done. The way I've used my students for this is we'll pre-round on the patients before they come in. So the student knows very specifically what changes need to be recommended. And then they can go into the visit, conduct a medication reconciliation, find out if there's other problems that have come out, tell the physician about those problems and about the things that we discussed changing, and then the physician can go in and make those changes. So the students have actually been able to expand and increase the number of patients we can see and make changes on in that way. And of course, one of the barriers is lack of reimbursement. So this is probably the biggest reason why pharmacists aren't in the outpatient setting. But this is changing. So like Dave mentioned in his presentation, paper performance is becoming a very big part of the clinic, and I'll talk more about that in a few minutes. But certainly, billing, if you only bill incident 2 for every visit that you have, you cannot pay a pharmacist salary. That's just not possible. But as I mentioned earlier, you can focus on other billing options, Medicare wellness visits and NTM. Those are ways to get more reimbursement or higher levels of reimbursement. And then also pay for performance. So does anyone know what pay for performance is? I know Dave talked about it a little bit, but in the outpatient setting, what's an example of pay for performance? Any ideas? Has anyone heard of STAR measures? Yeah, so that's very big, especially in the retail setting. It's a very big way, or a very big focus of practice. This in the ambulatory care setting, this is having an impact, specifically with Medicare Advantage plans. They are coming into clinics and putting it on the clinic in a lot of situations to improve those STAR measures. So in our clinic, and I'll talk about this in more detail later, there's a few of those measures that I'm actually in charge of trying to improve. And those are things that we can also give our students to help out with too. They learn a lot in that process. Okay, and then lastly, pharmacist time management. This is indeed an actual barrier. So initially, business is slow, but then eventually it gets to the point where the demand for your services far outweighs your time that you have in the clinic. And then you end up taking things home and you don't have a life. So you really do need to kind of anticipate this ahead of time and focus on the areas of the clinic where they need you the most. That is the best advice I can give you. If it comes up that you have 5 patients scheduled for anticoagulation and they need you to do something over here really quick, well you really need to focus on the areas where the clinic needs you the most. And the best thing you can do is again, communication with the clinic manager will also help significantly in this area. They can get you the resources you need to do things more efficiently, and if you're communicating with them and telling them what your schedule is like, it's much easier for you that way. So become very good friends with the clinic manager. Initially, so I have here, initially business is slow. The way to sort of get more patients and bill your schedule is to do automatic referrals. So in my clinic, any patient that needs an INR, I see them. There's no question. The physician doesn't have to send any messages anywhere. It just automatically goes to me. If a patient has an A1C greater than 9, it automatically goes to me. So those automatic referrals are where you can really build your service quickly. With the script study specifically, it actually turned out very well. The physicians, again, they did encounter all of the barriers that I talked about, but in the end, the physicians were actually afraid of the pharmacists leaving the clinic afterwards. They didn't want them to go back to the retail setting. They said, keep them here. We like them. So the pharmacist was actually viewed as a part of the team, and then they really liked that the pharmacist filled in these specific gaps. So they listed patient education, assisting with transition of care appointments, assuring appropriate medication use, assisting with formulary issues, medication adherence, and then conducting medication reviews and chronic disease management were also very important. And then lastly, these were very important to physicians, acting as a resource for them, so they didn't have to call and someone else and try to get information from an outside source. They could actually go directly to the pharmacist face-to-face in the clinic and get the information that they needed. And that was very important to them. And then it also freed up time for them to focus on more acute concerns. So if their pharmacist is managing their patient's chronic conditions and helping them with that, they have more time to then see more acute conditions that we're not trained to respond to. Okay, And so this is the pay for performance slide. So these are the areas where, in an outpatient clinic, I am focusing my time to try to improve our measures. So basically, pay for performance means that we are, and as I mentioned with the ACO, we are getting paid by CMS to improve our patients' health. And if we can show at the end of the year that we've improved their health, we get more money. So the measures that we have to meet are listed here. For specific Medicare Advantage plans, we have 2 different companies here that are working with us and wanting us to meet these goals. So each of these goals are MTM, for example. They want a specific % of patients that are covered in their plan to receive a CMR every year. And so they're asking me in some of those situations to provide those CMRs in the clinic. A1C control, so they look at the percentage of patients with an A1C less than 9, and obviously we want that number to be greater. So if they, let's say for example, if our goal has to be 80% in order to get paid by CMS, and our number is only 60%, they can give us a list of patients who are not meeting that goal, and we can see each of those and try to improve their A1C. A big one is medication adherence. So again, they can provide the clinic with a list of all the patients who are non-compliant with their medications, and we can contact those patients, find out if it's a cost concern, or if they're having an adverse effect, or if there's something we can change to improve their compliance with medications. And then statin therapy. Obviously, if the patient qualifies for a statin according to the new guidelines, that is an intervention we can also make. So we can either start a statin, or if they're not intolerant of a statin, maybe we could start a lower dose, or every, once or 3 times a week dosing, for example. There are some interventions we can make there as well. So again, I'm working on all these measures along with my students to try to improve the star ratings for those plans. And then as an ACO, we have 33 quality measures that we have to meet. And these listed here are all measures, again, very similar to on this side of the screen, but these are all measures where a pharmacist could become involved. Any questions so far? So now I'm going to talk about how we can incorporate students in all of this. So again, at Charleston Internal Medicine, we see patients for transitions of care, anticoagulation management, chronic disease management, and this is mostly diabetes that we see. We're also a drug information resource. We provide MTM. And the MTM that we provide for patients is using the Outcomes MTM platform, or Marixa is something we're also going to start doing. And if you're not familiar with Outcomes or Marixa, these are just platforms that we use for billing MTM services. MTM is not billed incident to in a clinic setting. And then quality measures that I already talked about. So if we look at each of these, how do we put students in this? What can they get out of these? Well, if we look at transitions of care, the student can interview the patient, huddle with the physician, and get that interprofessional experience that they need, and then provide those recommendations to the physician. For anticoagulation management and chronic disease management, they can be involved in the visit. So for anticoagulation, I have them interview the patient and actually make a recommendation for anticoagulation dosing on the spot in the moment, and then counsel the patient if they need to. For chronic disease management, they can also make recommendations for drug therapy changes. And anytime I want to clarify, anytime the student makes a recommendation for drug therapy changes, they make it to me, and then I approve that, and then it goes to the physician. So they're never put on the spot to come up with a therapy change on their own. And then they can also do physical assessments, blood pressure and heart rate for those patients. For drug information questions, I give these to the students to answer, and then they give them back to me to approve, and we send them to the physician. And a lot of times I'll have them actually go to the physician directly and provide them with their answers, so they do get that more practice with communication. And actually another part of this is in-services. So in the outpatient setting, very similarly to the inpatient setting, physicians really want that extra education. So if there's something, if there's a new guideline that came out, they love it if a student can give them a synopsis or a short presentation on the guidelines so they're more up to date. So in-services are also a good way to involve students in the clinic. NTM, if you're familiar with outcomes in MRICSA, there's a lot of documentation online that you need to do for that, and students can be very helpful in that regard. And they can also help you decide what therapy changes need to be made. So again, you can huddle on the patient, or pre-round on the patient sort of before you have those visits and talk about changes that you can make. And then of course with the quality measures, medication adherence, for example, I can have them call the patient and interview them, try to find out what the problem is with adherence, and if there's some change we can make. And then for the other situations like high-risk medications in the elderly or statin therapy, I can have them work up the patient and decide and look at what they've tried before, what hasn't worked, what has worked, and what we could potentially change for those patients, and then we can discuss that. And of course, in response to the 2016 standards, UCSOP has new requirements for the students. So for APP students, all of these things are things that they need to be doing in an ambulatory care setting. So some of the things that my students are already doing are SOAP notes, of course, for patients, drug information questions, a journal club presentation, and then a formal presentation to a group of pharmacists and students, or it could be to a group of healthcare professionals, or other healthcare professionals, I should say. Some things that I have been doing in the clinic that I need to now switch to having my students do and me evaluate is patient education materials. And there's always something that we can create in this area. We'll probably never get to the end of the materials that we can provide to patients, but so this is something that every block I could identify a resource that we need to provide for a patient and have the student work that up or create something. In-services is also something they can do on a regular basis. And then lead topic discussion. So instead of me leading every topic discussion, giving them a topic to research and create a presentation and then present that topic. DUR or drug monographs, that's something that I haven't been doing, but we could simulate if we needed to, or they could create a drug monograph and then expand upon that and also present, use that as their formal presentation if they need to. So there's some of these areas where the student could combine things so that it's not so much work for them to do. They could do 2 or 3 things in one area or one disease state, and it sort of all flows together. And in therapeutic protocol development, this might also be something that we would need to simulate, because these are not always changing in our setting. Then lastly, looking at IPI students, in this area I think it's most important to utilize the API student and use a layered learning model. And if you have a resident, actually utilize the resident as well. So the resident could model performance for the API student, who then models performance for the IPI student. And in order to do that, this requires timing or sort of delaying the introduction of the IPI after the API is already ready. So what I was thinking of doing, since having the IPIs in the clinic for a whole semester is new this year, I would try to time it so that my API students have already been there in the clinic for 1 or 2 weeks. They're used to the services that they needed to provide. They're used to talking to the physicians, for example, and they can then effectively model that behavior for the IPI student. And for IPI activities, they also need to interview patients and do medication reconciliation, present patients to me, and write SOAP notes, and do DI questions similar to the API. So hopefully they're seeing the API do all of those things and then modeling that behavior with their own projects. They also need to participate in a topic discussion and journal club, which are led by the API. And then they also need to provide written education materials and a formal presentation. So again, this is something that I put on here. It could be added on to what the API student is presenting for their in-service, for example. So maybe you have them collaborate on a project, and then one presents a big part of that and the other presents a different part of it. So these are ways that you can get them to interact more closely and model each other's behavior. Okay, so we're back to our scenario. So if you remember, you are a pharmacist in a family medicine clinic. You're the only one that's ever been there, and you have 2 API students and 2 IPI students each semester. And then you have a low-income population with obesity, cardiovascular disease, diabetes, and you have pediatric patients with asthma. And then your ACO has told you that you have poor performance with diabetes and with patients with cardiovascular disease taking cholesterol lowering medication. Now I want to kind of stop and just explain this one. So when the ACO requirements, the 33 requirements for ACOs was created, that was in 2011 before the new guidelines for cholesterol management came out. So they did not specify that patients need to be on a statin. They just said any cholesterol lowering medication. But now the Medicare Advantage plans, especially for the star ratings, they are looking at statin use specifically. So for these patients, we would also ideally look at statin use. So what services would you offer? How would you integrate yourself in the clinic? And then what activities do you think would benefit your students? So think for a minute, look at that clinic situation, and think about, well, for example, what would be your very first service that you would offer the clinic? How would you bill for your services, or would you bill for your services? And then how would you best integrate yourself into that clinic? Seeing as how they've never had a pharmacist before. Does anybody have any ideas?
I would try to set up the automatic referral thing, so I saw everybody that had the IO or the A1C is greater than 9, and then they get all the patients that were on the statin.
Yeah,
What was the
I
other
mean,
one?
yeah, so you could have an automatic referral process where every time you checked an INR, if it was above 9, they saw you, was their next visit. Or for the cardiovascular disease patients, there could be a way for you to kind of scan, as long as they have an electronic medical record, you could use that to identify all the patients with cardiovascular disease and even do a project or a study, quality improvement project in the clinic to identify those patients and then try to get them on a statin if they need to be. Good, that's a really good idea. Any other thoughts? How could we utilize students in this setting?
Could have students work up the patients beforehand, have them involved when you actually see the patient in the clinic as far as the interview, gathering information. They can even make recommendations to you and then educate the patient about the final decision.
Exactly, yes. And another thing that I think is very important in this setting is that the patients are low income and probably low health literacy. So this is where providing patient education materials could be very invaluable to this practice site. There are many instances where you could have your students, if it's a slow day, for example, go in with physicians and kind of shadow them, and then anytime something comes up with medication education or counseling, they can help out with those patients. So this would be a great learning opportunity for them. Okay. So basically this all boils down to opportunities for pharmacists in the outpatient setting are growing, and this equals opportunity for students. So this is a very big area where students can learn a lot and become more involved. So any questions about anything I went over today? Yeah.
Did you ever go over, what was the thing that the elderly have to do every November? What is the Medicare?
Re-enrollment, yeah.
Do you do that with them as well?
Yes. Actually, so this year, there is a resource here. Every state has I think it's Senior Health Insurance Information Program, or it's SHIP, basically SHIIP is the acronym. So West Virginia has WVSHIIP. And basically what that program does is it helps the patients pick a plan that is cheapest for them. It actually tells them when they'll go into the donut hole, how much money they'll spend in the donut hole, what prescriptions will be covered on which plans. So I really try to advertise that in the clinic, that service, and help patients be aware of that and and that they need to pick a plan that's best for them. A lot of seniors really just, they'll pick the same plan they had the year before and then not realize that all of the fees are going up the next year, the formulary is changing, and then they're, they're just out of luck, I guess, after that, they can't change anything.
Do you use any prediction, like what you think the patient may be running into chronic disease-wise that they may need in the future? For example, if you have somebody who has hypertension, diabetes, and hypercholesterolemia, are you looking at the renal function and thinking, oh, they're gonna have to get this later on?
That's a good thought. No, I haven't been, but as far as like picking a plan or?
Yeah.
Okay, yeah, and kind of anticipating the costs that they'll have. I don't know if they do that with that service maybe, but that's not something that I've been doing.
Okay.
That's a good thought though. Any other questions? Okay, thank you.
A lunch is ready next door, so we'll break until 1 o'clock, and then the next presentation will start at 1. So please help yourselves, and please don't be shy. We have lots of extra food, so you're welcome to eat in here